Couple of quick questions for you. What does a peanut say when it sneezes? What does a peanut say when it sneezes? Cashew. What do you call a bicycle with a pop tire? A bicycle with a pop tire. That's right, popsicle. And what do you call an alligator in a vest? An alligator in a vest. An investigator. That's all I got. Okay, with that, we're going to begin talking about respiratory diseases. And to start us out, we actually need to talk through a couple different categories. The categories that we're going to walk through are atelectasis, obstructive pulmonary diseases, restrictive pulmonary diseases, and then pulmonary infections. And there's many others, but this will cover quite a bit over the next two lectures. And in pulmonary infections as well, we'll cover things like pneumonia. We'll talk about SARS. We'll talk about COVID-19. So we'll cover a decent gamut of respiratory disorders. But first, before we get started, I want to remind you of this normal physiology, respiratory physiology out of 202, if you recall. And you can appreciate from this graph our total lung capacity of being about 6 liters in an average individual. And this is really based upon height more than anything, less about weight or size. It's more about height. So the taller the individual, usually the larger the thoracic cavity and the larger total lung volume that you have. So if you kind of look at swimmers, like a Michael Phelps, super long torso, and respiratory total lung capacity is huge in these individuals. So again, recalling back to 202, there's a volume that stays in the lung, that remains in the lung, called the residual volume, never really leaves, about 1 to 1.2 liters. About the same amount of volume, 1 to 1.2 liters, is the expiratory reserve volume, and about 3 to 3.3 liters is your inspiratory reserve volume. And in between these is tidal volume, about half a liter, 500 milliliters, which is what you're breathing right now, just at rest as you inspire and passively expire, actively inspire, passively expire. You're moving about half a liter of air. So if we look at the definitions of normal physiology, normal respiratory phys, and then we start talking about some of these terms like eupnea. Eupnea is regular normal breathing or healthy breathing. So the Greek eu is the word for well, and the pnea is breath. So it's like well breathing or well breath or good breathing. So eupnea is normal breathing. Dyspnea is a shortness of breath. And orthopnea is shortness of breath while you're lying down or in a horizontal position. We have hyper versus hypoventilation. Hyper meaning overactive or overly ventilating. So your ventilation exceeds what your metabolic demands are. Hyperventilation, like someone gets excited and they start breathing excessively, like right, they're hyperventilating. Hypoventilation is under breathing, or your breathing is below what your metabolic demands are. We've got hypercapnia versus hypocapnia, same thing, higher or lower. Hypercapnia is high CO2 in the blood. Hypercapnia, hypo is low CO2 in the blood. Hemoptysis is blood in the sputum or coughing up blood, hemoptysis. And cyanosis is a bluish tint or a bluish color to the skin or the mucosa. And that usually is an indication of decreased oxygenation happening. Hypoxemia, not necessarily hypoxic, but hypoxemia is a decrease in oxidation of arterial blood. And hypoxia is decreased oxygenation of the tissues or the cells. So hypoxemia is talking about the blood, hypoxia is talking about the tissues, and then not on the sheet, but relevant is ischemia. And ischemia is a restriction in blood flow. So you could write ischemia down here, a reduction in blood flow, which may lead to a hypoxic environment in the tissues or the cells. So just some definitions for us to take a look at. Just going to check the feed real quick, make sure that the recording's good. Any questions on these definitions? Excuse me, sorry about that. Okay, great. Atelectasis, first up. So atelectasis, simply put, is lung collapse. So the lung collapses due to inadequate expansion. You can kind of see in these pictures, we've got an absorptive type where you get a collapse from the top aspect. You've got a compressive type, which is from a lower or inferior aspect. And you've got overall contraction, which is all around the lung itself. So when you have atelectasis where you get a lung collapse, it's not expanding adequately, this causes a reduction in oxygenation. The lung can't inflate enough. If it doesn't inflate, you're not moving as much air. You're not loading the hemoglobin molecule on the red blood cell. And so you'll lead to hypoxemia and hypoxia in the tissues, or hypoxemia of the blood, low oxygenation of the blood, hypoxia, low oxygenation of the tissues of the cells. So in resorption, this is where obstruction prevents the air from reaching the distal airways, resorption. So the alveoli collapse. Under compression, it's usually due to an accumulation of blood or fluid because it's going to sink down, it's heavier. So due to gravity, fluid and blood's going to kind of pool at the bottom part or the inferior part of the lung and create a compressive where you can't take as deep of a breath because you've got fluid, which is a non-compressive material, right? Fluid is non-compressive, air is definitely compressive. So this non-compressive fluid restricts the expansion of the lung in compressive. So fluid or air in the pleural cavity, this is also what happens commonly in compression during chronic heart failure or CHF, where you get a lot of pleural effusions or fluid that's leaking because the heart is not contracting efficiently, and it pools below the lung, and the patient feels almost like a heavy chest. It feels like somebody's sitting on their chest while they're trying to take a breath. This is also what would happen in a pneumothorax. Any ideas what a pneumothorax is? Yeah, that's right. So where you have a disruption in the pressures from the outside environment to the pleural cavity, because it's a slight negative pressure inside. And so if you have like a puncture wound or trauma or a knife wound, if you will, something punctures into the chest cavity, that's considered a pneumothorax. You know, pneumo meaning lung, thorax meaning chest. So the lung chest area is compromised. In contraction, this is where you've got situations where you've got a decrease in a decrease in elastic recoil and an increase in fibrosis of the lung. And we'll kind of look at that in some of the diseases that we talk about here next, okay? Contraction. So atelectasis, lung collapse. As we move on, this is chronic obstructive pulmonary disease, COPD part 1, chronic obstructive pulmonary diseases in our list. So obstructive pulmonary diseases, These are typically worse with expiration, when you exhale. It's not that they don't struggle with inspiration at all. It's just it's more exaggerated during expiration, right? So that confuses students sometimes. They're like, well, I have asthma and I'm having an asthma attack. It actually feels like I have trouble breathing in air. Well, that might be true because you have a restricted airway. But the way that we diagnose asthma is on expiration. So it's a forced exhalation over the first second. And we'll talk about this later in the lecture, but the air that you exhale in the first second, that percentage of the total amount that you can exhale is how you clinically diagnose if a patient has asthma. So it's more exaggerated on expiration. But you've got a reduction in airflow due to some kind of blockage. In asthma, it's obviously the blockage is because the airways are restricting. But in other types of situations, like bronchiectasis, emphysema, or chronic bronchitis, and these two are the two categories that are classically referred to as chronic obstructive pulmonary diseases, or COPD. And asthma is not in that category because usually asthma is episodic. It's not chronic. People don't live with asthma symptoms all day long. They take an inhaler, or they take a medication, or they get a nebulizer treatment to relieve their symptoms. Whereas with emphysema and chronic bronchitis, there's really no relief. So that's why it's considered chronic, and asthma is not. Bronchiectasis is a total change in the architecture of the lung. We'll talk about that one. So it's kind of its own category. So we're going to walk through all four of these. So first up, emphysema. So emphysema really affects the alveolus mostly, but it affects the acinus, and the acinus is basically the alveolus, the alveolar duct, the respiratory bronchiole. All of that respiratory zone is considered the acinus, if you remember from Respiratory Phys 202. What happens, you can see the normal architecture here in this cartoon drawing, and then what we call centra-acinar emphysema and pana-acinar emphysema. Pana-acinar emphysema really primarily affects the alveolus and the alveolar duct, and centra-acinar, which is the most common, affects the respiratory bronchiole. But what you do is you have this sort of expansion. You lose the structure of the acinus, or the alveolus, or the respiratory bronchiole, and it kind of blows out. And as it blows out, you lose the surface area. So you get this enlargement. And you might think, well, isn't that contrary to logic? Like, if it gets bigger, doesn't the surface area go up? Well, not necessarily. So think about all of these little folds are increasing the surface area versus having it just be a straight line. So as this blows out, you lose a lot of these folding, and you create less surface area. You have less of the folding. It just kind of, it's a flat balloon versus one that has all of these folds. Think about like the intestines, or think about the way the brain is organized, like increasing surface area, we're having more and more folds. So as you enlarge this, you lose the folds, and losing the folds means you lose the surface area. So you have less area for gas exchange, essentially. Physiologically, gas exchange area goes down, and it's due to a loss of elastic recoil. And so as the patient expires and inhales, inhalate, exhalate over and over again with a loss in elastic recoil, that acinus kind of blows out. The histology up top, so you can kind of appreciate if I trace this. This is a blown out alveolus. Here's another blown out alveolus right here. So this is emphysema. And the centra-acinar being the most common is really primarily due to cigarette smoking or tobacco use. It's more common in the upper lung lobes. Para-acinar is more common in the lower lobes of the lung. And from a disease state, what we see is pathogenesis It's not completely elucidated, but we've got some reasonable explanations about what's going on. So let me walk you through this. Start at the bottom. There's a population of patients, and as you move into the clinical practice, I want you to appreciate this. Not everybody that's going to present clinically with emphysema was a smoker. So kind of drawing that conclusion or prejudging the patient, oh, well, so-and-so, in room 12, I've got a chronic smoker with emphysema. Well, that very well could be the case, but there are patients that have emphysema that develop a chronic obstructive pulmonary disease that never smoked in their life. What? That doesn't make any sense. What happened? Well, there's an enzyme known as alpha-1 antitrypsinase. And this alpha-1 antitrypsinase is a antiprotease, so it inhibits the activity of elastase. Elastase is an enzyme that breaks down elastin. So we have an enzyme that blocks the breakdown of it blocks the activity of the enzyme that breaks down elastin. Let me say it again. Elastin is a stretchy protein in the lungs. It allows for like an elastic rubber band, elastic recoil. There's an enzyme known as elastase that breaks down elastin. And the antiprotease, the antitrypsin, blocks the elastase. If you have a deficiency in the blocker of the enzyme, then the enzyme is able to go out of control. You follow? Let me repeat. Elastin, stretchy protein in the lungs, allows it to elastically recoil, has an enzyme that breaks down the protein, elastase. We make functional antitrypsin or a blocker of that enzyme, elastase. If you have a congenital malformation or deficiency of that enzyme, you have too much elastase floating around. And those are patients that have a predisposition to developing emphysema. Now, if they smoke on top of that, could exaggerate it. So, tobacco smoke releases all sorts of reactive oxygen species, free radicals. These free radicals cause tissue damage. They actually stimulate the recruitment of inflammatory mediators out of the blood cell, like neutrophils. They come into the area and they increase the presence of elastase. Well, tobacco smoke also inactivates that alpha-1 antitrypsin, or that antiprotease. And so it's like a combination, or the perfect storm, if you will, of all of these factors playing into the breakdown of elastin, leading to a loss of elastic recoil, leading to emphysema. But this also helps to explain that, so there's environmental factors and there's genetic factors. So some patients that have smoked their whole life and they don't have emphysema. You're like, I seriously think if they, Uncle Joe, if he stopped smoking, he'd probably die. But he smokes like a chimney and he's relatively healthy. I don't get it. And then other people smoke and, they get lung cancer in their 40s, right? Well, because of this genetic component. So there's multiple things happening, which is why it's not super clear. We've got an antioxidant oxidant imbalance. We've got a protease antiprotease imbalance. And then we have a genetic component as well as an environmental component, all kind of coming into play for these patients. So environmental and genetic. So the clinical features of these patients, and these are kind of not comical, but they make me chuckle a little bit. Like if I ran into this guy on the street, I'd never know who he was because I never saw his eyes, right? I guess this is, okay for us to show just with eyes blocked out. But so they have shortness of breath. They're barrel chested because they're working harder to expire. So as they work harder to expire, it like increases the size of their expiratory muscles. So they kind of work out their expiratory muscles and they end up becoming a little bit more barrel chested. But they have significant weight loss over time. So This individual doesn't look all that barrel chested. He looks pretty thin. But if you look at his musculature, it's pretty well developed for how thin he is because he's exercising extra hard to expire. And they're called pink puffers because they tend to have to sit forward in a hunch position to kind of force air out. So they kind of go a little red in the face as they progress in life. Let's contrast emphysema with chronic bronchitis. So clinically, it's often not one or the other. Patients who have emphysema will have some symptoms of chronic bronchitis as well. But for an academic exercise and on the exam, I want you to consider them mutually exclusive. Okay? If I ask a question about chronic bronchitis, I'm asking about just chronic bronchitis. If I ask a question about emphysema, I'm asking about pure emphysema. Now, I recognize clinically that's a little unusual that you would see just one and nothing from the other. But for academic textbook studying, consider them mutually exclusive. Does that make, are you tracking? Okay. So in comparison to emphysema, these patients have a persistent cough. 90% of them are smokers. Now, again, you could have an emphysema patient that was a smoker, and they might develop chronic bronchitis symptoms. But over here, we have the acinus being impacted, and we're blowing out the alveoli and the respiratory bronchioles. We're losing elastic recoil, and we're losing our surface area. Over here, we get a lot of inflammation and secretion of mucus. The large large airways, you get overproduction of mucus or hypersecretion and inflammation in chronic bronchitis. In the small airways, we get some fibrosis of the airways, and we get airway obstruction that takes place as the airways kind of narrow. Chronic bronchiolitis. Bronchiolitis, chronic bronchitis is the large airways. So, kind of a different manifestation of two different diseases, right? One's an airway problem and hypersecretion and inflammation and fibrosis. And the other one, the emphysema, is a sinus or a alveolus problem. So in chronic bronchitis, we typically diagnose them as having a persistent cough for at least 3 consecutive months in at least 2 consecutive years. There's mucus present, the airway's not obstructed, but a lot of times in these chronic bronchitis patients, there's so much mucus that it kind of blocks the respiratory tree. And you hear that kind of smoker's cough, right? Where they're like, and it's like raspy, and you're like, man, I just feel like I should pop them on the back because they need to hawk up a loogie, right? So you kind of hear that raspy cough. That's the mucus that's kind of resonating as they pass air from a cough through their airways. So in these patients, we get like a loss of pseudostratified epithelium. You can see the normal picture up top, and you can see those nice cilia of the pseudostratified ciliated epithelium. We lose that epithelium. There's an environmental trigger often that happens from the mutagens and the carcinogens in cigarette smoke that causes a mutation in the mucin gene, and this increases goblet cell activity. So they make more mucus, copious amounts of mucus, usually begins in the large airways and then makes its way into the smaller airways. And often they have reoccurrent infections because they've got this mucus that's sitting in there and just kind of going rancid. The histology image that you see at the bottom, you've got a tremendous amount of inflammatory cells. All of these purple dots are all inflammatory cells that have actually infiltrated into the respiratory parenchyma, or the area of the bronchus that's in the respiratory parenchyma. So these patients with emphysema, they're considered blue bloaters. because they usually have um, uh, more susceptibility to kind of deal with um, the extra CO2. They're not breathing as well. They tend to be a little hypoxic and cyanotic, but they kind of just deal with it. They've gotten used to it. So blue bloaters is they're a little bit more cyanotic because they're hypoxic. They tend to be a little bit heavier versus losing weight because they're not working as hard to expire. They're just sort of kind of living with the new physiologic abnormality of being hypoxic. The airways tend to close off during expiration in these patients as they cough because the mucus blocks. And so the brain kind of resets in the respiratory centers in the brainstem to be hypercapnic and be okay with higher levels of CO2 that allows the patient to kind of give off this cyanotic or this blue appearance. So they have shortness of breath on exertion, so then they don't exert. They don't work as hard. They breathe less because it's complicated when they try to exhale. So they just exhale fewer times. They get a lot of sputum, so it's kind of socially awkward because they're coughing and people are looking at them like, are you going to like spit that loogie somewhere? So they just sort of don't do it. But it's also often common to see both chronic bronchitis and emphysema together. But again, on the exam, just read it carefully, or on a quiz, if I'm asking about emphysema or bronchitis, I'm trying to ask you a question about those particular cases separate from each other. Questions? Okay. Let's talk about e-cigarettes and vaping. So this is an interesting topic for me, and I've sort of alluded to this earlier in the semester, but I've been teaching this class for so long that it predated vaping, or e-cigarettes as we used to call them. And I remember getting questions from students like, well, hey, in the early years, man, is this like an alternative that's safe? And it was early and nobody really had any data, but I just, my knee-jerk reaction was, well, I'm guessing in about a decade, we're going to have data to demonstrate that it's not safe, because this is a hypothesis, but you're breathing air that you can see, air that is full of chemicals of some sort. Okay, maybe it doesn't have as much tar, or maybe it doesn't have as much of the pollutants in a cigarette, agreed, but it still has substances that aren't in the air that we breathe. Like, you're not really built or designed to breathe air that you can see. I mean, you if it's a smoky day, there's a prescribed burn, and a lot of times people are like, well, I'm not going to go for a run today. There's like so much smoke in the air, right? That's like common sense. But yet, with e-cigarettes and vaping, we sort of lose that common sense. So my prediction was, and again, I'm not trying to brag, but my prediction was, I don't think it's too big of a stretch, right? Like 10 years ago, it was like, yeah, we'll probably eventually get data to show that it's not good for you. Well, I wish I was wrong, actually. And I was right. And you probably are like, yeah, it makes sense. I mean, I could see why it wouldn't be good for you. Well, so I kept this slide from way back then. I modified it by saying it's no longer not clear. It's not safe, no surprise. These vapes or e-cigarettes, electronic cigarettes, it's typically some sort of battery-operated atomizer that heats a liquid that contains nicotine or a drug of interest, and it turns it into a vapor that can be inhaled and brought into the respiratory epithelium, brought across the blood interface, and enter the bloodstream, and then you feel the effects. Manufacturers claim that they're a safe alternative, but cigarette manufacturers claim that for many, many years in courtrooms. FDA has questioned the safety of these products from day one. It wasn't just me. It was me reading their stuff and going, yeah, I don't know. The samples that they tested in the early days did see trace amounts of toxic chemicals and carcinogens, albeit less than in cigarettes, which is where that popular opinion came that maybe they're a safe alternative. So you can kind of see a diagram here of how most of them are built. You know, if you see the LED light that gives that visual feedback, you've got a battery, you've got a microprocessor that controls the heat. There's a detector for a pressure differential when the smoker takes a drag. So there's a pressure differential that triggers the heater to vaporize the nicotine or the drug of choice. And then it's dissolved typically in propylene glycol is most of the components that give you off that smoke. So lots of resources. This is in your slide deck. This is off the Center for Disease Control. And this is highlighting some cases of lung injury associated with the use of e-cigarettes or vaping products. So I'm going to walk through this. This is in the Washington Post. They performed the first double lung transplant on a patient who was a vapor. This was a 17-year-old male, younger than most of everybody in this room. 17-year-old male. 6-hour transplant surgery. He had complete lung failure. Is it safe? No. Keller, that's an N01. Okay, fine. N01. Lung injury cases, this is as of 2019. You can just see that the data is starting to mount. It's growing. 8 cases that were reported. This is 2019, American Journal of Clinical Pathology. Lung biopsies. Now they're biopsying severe pulmonary illness with e-cigarettes. All right, so now the data is going to come out. Here we go. Imaging. All right, so 4 different patients. This is CT, computed tomography imaging. So this is through a transverse section here, right through the chest. Patients left, patients right. So the lungs here, all of this white area shouldn't be there. Those are consolidations, is what opacities or consolidations that we call them, which means that there's some sort of abnormality that shouldn't be present. You basically have fluid collecting or edema in the lungs. Here, there's a hot spot towards the anterior aspect. So here's the vertebral column, anterior aspect. You see all that white cloud? It's absent in this patient, present in this. I mean, these are 4 separate patients. This patient, again, looks a little bit more like this patient, but it has more of these nodules, these white nodules. Again, 4th patient. So we're collecting more and more data. This is a normal lung CT. This is what we call an EVALI lung CT. So now we can diagnose this. EVALI is e-cigarette or vaping product use associated lung injury. Let me say it again. E-cigarette or vaping product use associated lung injury. EVALI. We actually name it now. We have a name for it. So under imaging, don't have to have a biopsy, but you can actually determine if patients are having a poor response to e-cigarettes or vaping products. Now we have histology, right? We're doing biopsies, we're doing transplants, so we can actually take a peek at these things. Up in the upper left, what you're looking at, these are foamy macrophages. Foamy macrophages mean macrophages that are actually taking up like lipids. We call them foamy. We see it in cardiovascular disease, like in atherosclerotic lesions. So this area right here, all this area up until where this little left corner is, this should all be white. And it's full of all of these macrophages. Here we've got intraalveolar macrophages. So these ones that are, not kind of like collected, but all look like individualistic. You see how these are like all bunched up? These are in the alveolus. So we have intraalveolar macrophages. These are macrophages in bronchoalveolar lavage. So they come down in with a scope, with an instrument, and they suck out fluid out of the alveolus. Sounds horrible, right? And that fluid contains those macrophages. Well, number one, there shouldn't be fluid there. Like you're starting to drown. But that fluid is what you're seeing collect in the imaging. Like fluid shows up with a white opacity. And then these are just activated macrophages. They're positive stain for an activation, meaning they're activated macrophages. That means they're in an active state of inflammatory response. So normal lung. So I was telling you, like right up here, right up to this border where these, like kind of pink upper left, all of this should be white. It should be open white like this, because that's the alveolus. And it's full of all these macrophages. I mean, this is a pretty severe EVALI lung patient. So what we know, not safe, but here's the numbers. As of 2020, there's been about 2,800 cases of e-cigarette or vaping product use-associated lung injury that have been reported to the CDC. This is US numbers only. 68 deaths as of today, as of 2025, this year. 68 deaths. Well, that's not that many, Keller. It's like, yeah, it's not, but most of these are young patients. You got a 17-year-old getting a transplant, right? I mean, yeah, these are not big numbers, but most of the vaping that happens is in younger populations, right? Let's be honest. There shouldn't be any deaths in those populations with lung problems. And it appears that the vitamin E acetate might be the issue. And so, of course, manufacturers can eliminate that. But I go back to my sort of original hypothesis. Should we be breathing air that we can see, that has stuff in it? I think the answer is probably no. Probably not a good idea. Questions? Okay. Let's do part 2 of obstructive pulmonary diseases. And then we'll get on to restrictive. So the second part involves asthma and then bronchiectasis, right? So asthma is an obstructive disease. Usually asthma will start in childhood. 2 main types. There's intrinsically stimulated or there's extrinsically stimulated. So extrinsic first. So extrinsic stimulated asthma would be like allergy-induced asthma. Pollutants like ozone or smoking, air pollution. Obesity can cause extrinsic asthma because obesity can lead to a lot of gastroesophageal reflux disease, GERD, and you get, kind of slight regurgitation coming up. And in patients that are obese, they have less muscle control, and so they can aspirate, unfortunately, some of that regurgitated stomach contents. That can irritate the airways and cause restriction. And it's thought that maybe asthma may have some sort of evolutionarily beneficial significance. I don't know. The evolutionists love this, right? I'm not sure there's much to this, but I'll bring it up because maybe it's a protective mechanism where if there's a environmental microorganism that you don't want to breathe in, you restrict the airways and you breathe in less. Well, then my counter argument would be you restrict the airways so much and you die, then you don't replicate and reproduce and carry on your genome. So I'm not sure it's helpful, but because in severe cases, asthma can cause death, right? Like if we're talking evolutionarily, like thousands of years ago, there were no inhalers. So if you had an asthma attack, you're kind of like host, right? Intrinsically, we don't have any IgE. Like if there's a allergen, it's an IgE-mediated hypersensitivity. But intrinsically, there's no allergen, so no IgE with intrinsic. But things like cold, air, exercise, stress, these could be intrinsically stimulated bronchial constriction. Intrinsically stimulated bronchial constriction. So Um, one of the prescriptions, if you will, of how to exercise if you do have asthma is warm the air before you breathe it in. So breathe in through your nose if you're running outside in the wintertime, and out through your mouth, right? You filter the air, which is nice. You warm it through the nasal concha and then bring it into the airways as warmer air, so you're not causing an irritation of the airways that could be an intrinsically stimulated bronchial constriction. So that's one of the reasons for that. Okay, some diagrams on the right. You can kind of appreciate the mucal lining here. You can see a pollen allergen binding to a dendritic cell, kind of stimulating the immune system to release all sorts of granules like histamine. You move down here with your mast cell, triggering the histamine release, making more mucus, causing bronchial constriction, and you increase the vascular permeability and trigger fluid production, like transudates, a lot of mucus and fluid in the airways. In the late phase, the mucus kind of covers the airways, kind of leading to respiratory sputum, blocks airflow, becomes restrictive, kind of like chronic bronchitis in those patients. In the late phase with asthma, like hours later, if it's no inhaler on board or nearby, then you've got a lot of hypoxia, cyanosis, because it's shortness of breath while you're trying to expire. Histologically, we can appreciate in this, this is cartilage on the left and this is cartilage on the right in the respiratory tree. And so everything in between here, and this is a higher magnification, is all infiltrate. This is all infiltrate. So you've got edema, mostly eosinophils, edema and inflammation during bronchial asthma. And this is, hours later after, no rescue inhaler is around. Okay, so if you have a rescue inhaler, you don't see this. You dilate your airways the moment you feel the restriction. All right, last but not least, and then we'll get to restrictive, is bronchiectasis. Bronchiectasis. So in bronchiectasis, you've got permanent bronchial dilation due to some obstruction or some abnormality like a disease known as cystic fibrosis. You could have a chronic infection, like a chronic necrotizing infection. In this image that you can see grossly, do you see these little caverns or these holes? So this is where you've got a cystic fibrotic lung, where you're getting fibrosis of the lung parenchyma. You get dilation due to the chronic inflammation that takes place and the destruction of the bronchioles, bronchi, and it leads to permanent dilation. So you get like these openings that take place. And we saw some examples of this when we looked at tuberculosis infections, when we looked at necrosis. Do you remember that? In the very beginning of the semester. So there's often sputum that is prevalent or copious, a lot of it. It's infected, so it's foul smelling. It smells rancid. Shortness of breath, cough, fever, because they have a systemic infection. And they're at a higher level of risk of bacterial infection. So these patients with bronchiectasis, this is a permanent dilation of the bronchial airways, a permanent dilation due to this inflammation. Questions?